All right, so for the endocrine system, it consists of both the glands and the respective hormones that travel throughout the circulatory system toward their respective target organs. The master gland is known as the pituitary gland. It's composed of both the anterior or the adenohypophysis and the posterior or the neurohypophysis. The hypothalamus is a regulatory center and controls the pituitary gland. Hormones that are secreted by the anterior pituitary gland include thyroid stimulating hormone or TSH, adrenocorticotropic hormone or ACTH, prolactin, PL, growth hormone, GH, and gonadotropins such as follicle stimulating hormone or FSH, and luteinizing hormone or LH. The posterior pituitary gland secretes something called oxytocin, which is responsible for something called the letdown reflex. In addition, antidiuretic hormone, or ADH, which reduces urine production, is also known as vasopressin. TSH, FSH, LH, ACTH, growth hormone, and prolactin are all considered something called tropic hormones. That means that these hormones exert their effects on the other target organs, but by themselves don't have a specific function. TSH stimulates the thyroid gland to release thyroxine, or T4, and triiodothyronine, which is T3. These influence metabolism specifically. Calcitonin is also secreted by the thyroid gland. However, it decreases serum calcium levels. Now, behind the thyroid gland, you have something called the parathyroid gland. And these glands secrete something called parathyroid hormone or parathormone, PTH. And what these do is that they increase blood calcium levels. ACTH acts on the adrenal glands, which are composed of the adrenal cortex, which secrete aldosterone and cortisol, and the adrenal medulla, which secretes something called catecholamines, which are epinephrine and norepinephrine. And these are controlled by the nervous system. Growth hormone aids in the growth and development. GH directly influences growth at the epiphyseal plates of the long bones, which ossify by the end of puberty. Now, this is an important component for you guys to understand because when growth hormone is increased as a disorder, if it happens before puberty is over or after puberty is over, it'll affect the manifestations significantly. Calcium is stored in the bones and teeth. Calcitonin decreases blood calcium levels through means of deposition into bones. And the parathyroid hormone, or PTH, increases serum calcium levels by reabsorption back into the bloodstream. Prolactin aids in milk production, while oxytocin helps eject milk from the mammary glands. And that's part of the letdown reflex. As the uterus contracts after birth, which stops the bleeding, and also you have the ejection of breast milk, which helps the baby feed better. The pancreas plays an important role as well in the endocrine system by releasing something called insulin, which decreases blood sugar levels, and glucagon, which increases them. As TSH increases, the thyroid gland responds by increasing its secretion of T3 and T4. And when this is happening excessively, this is called hyperthyroidism or Graves' disease. In Addison's disease, there is a decrease in the secretion of aldosterone and cortisol, which places the patient at risk for hypoglycemia, but most importantly, hypotension. In Cushing syndrome, dietary modifications must be made, which include low sodium and an increase in potassium. In pheochromocytoma, this is a condition where the adrenal medulla is secreting an excess of catecholamines, and this will eventually manifest in hypertension. In hyperparathyroidism, serum calcium levels increase and place the patient at risk for something called urolithiasis or urinary stones. Hypocalcemia may result in muscular tetany, which may compromise the airway. And you must look out for something called a positive Chvostek's or Trousseau sign, and these indicate hypocalcemic tetany is imminent. A thyroidectomy may cause some unexpected adverse effects as well, such as a thyroid storm and hypocalcemic tetany. Patients must be monitored closely for these specific post-thyroidectomy complications. Adrenal insufficiency may cause a drop in blood sugars, and again, most importantly, a drop in blood pressure. This may be induced by abruptly stopping steroid therapy when the patient's on it, so it must be slowly weaned off or tapered off. In diabetes insipidus, or syndrome of inappropriate antidiuretic hormone, or SIADH, these are issues with an abnormal secretion of antidiuretic hormone, or ADH. In DI, it manifests with polyuria due to a lack of antidiuretic hormone. And in SIADH, it will manifest as oliguria due to an abundance of antidiuretic hormone secretion. Fluid volume excess in SIADH will demonstrate a urine-specific gravity that is high and low serum osmolality. DI includes a low urine-specific gravity and a high serum osmolality. In gigantism and acromegaly, they're both caused by an increase in growth hormone. However, gigantism occurs during childhood before the epiphyseal plates have fused. So these kids get really big, really tall. And in acromegaly, it occurs already in adulthood where the epiphyseal plates have already fused. So these patients don't necessarily get taller, but their hands, feet, and other features get more robust and large. Hyperglycemia causes polyuria, polydipsia, and polyphagia. Hypoglycemia manifestations are brought upon by activation of the sympathetic nervous system, which includes nervousness, tachycardia, sweating, and shakiness. And high serum glucose levels will eventually manifest with the development of ketones, and both of those damage the nerves and the blood vessels, and this leads to neuropathy and poor circulation in the diabetic patient.